Urinary key terms is the next topic here. So let's review the normal function of the kidneys, then we'll go into the need to know key terms for your pathophysiology exams. Renal anatomy and physiology. The kidneys kind of function like two washer machines, helping to wash the blood from waste, toxins, and impurities, but also to help regulate fluid volume by reabsorbing water from being lost in the urine. Now, in terms of location, the kidneys are located in the center of the body and receive blood from the heart. So just think after blood leaves the heart from that left ventricle, 25% of the cardiac output, this blood coming out of the heart, goes directly to the renals via the descending aorta. Like a one-way ticket to Kidney Town. Yoo-hoo! Now, once blood gets sucked into the kidneys, the first stop is the nephron, aka the functional unit of the kidney. And this is where all the action happens. Inside, we have these little high-powered washers called the glomeruli, a network of small blood vessels, or capillaries, located in the beginning of the nephron. And inside the glomeruli is the Bowman's capsule of the renal corpuscle. And this is where blood gets filtered and cleaned, kind of like a washing machine bubble. I mean, the picture even looks like a washing machine here. Okay, now this is a lot of nice to know anatomy here, but the highly tested need to know information for the NCLEX and nursing exams, key term, write it down, is GFR, the glomerular filtration rate. Over 90 mLs per minute is normal. Write that down. This helps us to assess how clients' kidneys are functioning and comes very, very handy when assessing renal failure, those failed washer machines here. Now, in terms of the functions of the kidney, the memory trick we use is free, like free the P. F is for filtration of waste, medications, and electrolytes, because we know where fluids flow, electrolytes go! And R is for reabsorption of water with ADH, the antidiuretic hormone. So the memory trick we use is ADH, add to H2O, keeping water in the body and not in the potty. And E is for erythropoietin, which is a hormone released by the kidneys that stimulates bone marrow to produce RBCs, those red blood cells which help carry oxygen around the body. So when the kidneys fail, we get very dirty blood, filled with waste, electrolytes, and we retain a lot of water, as well as low RBCs, that low blood count, which is called anemia. Now, we break this all down in the renal failure lectures, but this is why it's so important to know the physiology and patho first. So you don't have to memorize, you can actually understand what's going on in the body. Now, Hesse mentions the 3 phases of urine formation, and the answer is filtration, reabsorption, as well as secretion. So the key term here is filtration. Now, speaking of filtration, as mentioned before, the elimination of medications. This is the last stop of pharmacokinetics. When drugs are done in the body, well, then they go into the potty. This is where we get the term half-life, meaning how long it takes for half of the drug to be used up in the body, and finally E, eliminated into the potty. Okay, now for the need to know patho key terms. First up is anuria, basically meaning no urine output. Next is oliguria, decreased urine output. Next is polyuria, for that increased urine output. And we have pyuria, which is white blood cells or pus inside the urine, typically from a UTI, that infection. And we have nocturia, just look at the knock for nocturnal, so frequent urination at night. And nephrotoxic, key term here is toxic, so toxic to the kidneys. For example, drugs that could be toxic like antibiotics or even CT contrast dye, which can be very toxic to the kidneys. Next is retroperitoneal, the area outside or behind the peritoneum. This area is also called the peritoneal cavity, but the peritoneum is the tissue that lines the abdominal wall. That covers most of the organs inside the abdomen. So when this area gets infected, it's known as peritonitis. The next term is really strange here, so listen close. Azothemia or azotemia is high levels of nitrogen waste, mainly created by urea and creatinine. Now, speaking of creatinine, this is the one to know, so please be sure to pay close attention here. You're going to hear it a lot in med-surg as well. So creatinine is a muscle waste product of creatine breakdown. Now it's considered the most critical kidney lab in seeing if the kidneys are functioning properly. It's way more important than BUN in measuring kidney function. So for the memory trick, think of the 3 C's. C for creatine is a critical kidney lab because it shows clogging of the kidneys. So just think creatinine over 1.3 is bad kidney. And trust me, this key number will come up time and time again on exams and ultimately your NCLEX, since it can indicate acute renal failure, where the kidneys aren't washing the blood properly and everything gets clogged up. So just remember, as a general rule, the most deadly conditions are typically the most tested conditions. Okay, now for BUN. BUN is blood urea nitrogen. So urea is a waste product made by the liver when the body breaks down protein. A BUN test is done to see how well the kidneys are working, but it's really more useful in predicting dehydration. So just think when the BUN is high, then the body is dry. Or think if the BUN is high, then it's like you have burned buns with BUN. Like you went outside and got burned buns, and now you have high BUN. Okay, now lastly is GFR, the glomerular filtration rate. This estimates how much blood passes through the glomeruli each minute. And as you know, the glomeruli are the little washing machine units inside the kidneys. So the glomeruli are tiny little filters in the kidneys that filter waste from the blood. This test becomes very important when diagnosing the stage of chronic renal failure, which we cover in great detail in the renal failure videos. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And BPH, benign prostate hyperplasia, is prostate enlargement which compresses the urethra and surrounding bladder, making it difficult to urinate. Most common in males over 50 years old. Now the memory trick, just think BPH, a big prostate that holds back urine. Naturally, the signs and symptoms include urinary retention leading to a UTI infection, which is a priority complication. Now the key terms to know is sensations of incomplete emptying, described as keywords. Clients feel the need to urinate again immediately after urinating, and urinary frequency and nocturia, having to urinate especially during the night, described as a need to awake at night with an urge to urinate, as well as straining to void or difficulty initiating urination, described as a strain to begin a stream of urine, and a weak stream with slow dribbling of urine after voiding, described as keywords, stream of urine that is weak or intermittent, and low back pain as mentioned by Kaplan. Now these keywords listed here love to show up on Select All That Apply questions, so be sure to write them down and don't let the NCLEX trick you here. Frequency of sex is not related to BPH. Many students get this wrong. Now for complications, as mentioned before, that are not normal, the big key one here is a UTI infection. Write that down. So burning sensation with urination or even cloudy or smelly urine. This is priority. It indicates an infection from urinary retention. So the first priority here is to follow up with these findings and assess further. Now treatments include bladder training, drugs, and surgery. So for bladder training, we put our patients on a voiding schedule and we teach them to avoid caffeine. And for drugs, we use finasteride, brand name Proscar, which shrinks the prostate. So Hesse mentioned, what medication will shrink the prostate? And the answer is finasteride. So the memory trick, think of a man with a swollen prostate riding around on a horse. Ouch, that's a very painful ride. So just think, if you want to have a fun ride, get finasteride. Now this medication takes a few months to start working. So a big test tip to write down is that missing a few doses will not cause immediate or long-term effects. That was a commonly chosen wrong answer on a few question banks. Now, if drugs don't fix the issue here, then we can always do surgery, and we have two types. A TURP, which is a transurethral resection of the prostate. This surgical procedure is least invasive because instead of opening up the patient, we simply insert an instrument directly through the urethra to remove the prostate. Now, a prostatectomy is more invasive as it requires a surgical incision, basically cutting open the patient. So TURPs are typically chosen as first treatment due to the fast recovery time. Now, HESI mentions BPH that has been refractory to treatment with other medications. The answer is anticipate a TURP. Now, after either procedure, a 3-way Foley catheter is used for continuous bladder irrigation. This gives pressure to bleeding tissues and allows urine drainage. So the key points to write down: normal expected findings immediately after the procedure is bloody urine. Then, 24 hours after, the urine is light red and pink, and 36 hours max, we expect small blood clots. Again, all are normal during these time frames, but not after. So, bloody urine after 24 hours is not normal. And small blood clots after this 36-hour window, again, not normal. So don't let the NCLEX trick you here. Blood clots seen on day 2 is a priority finding and should be reported to the HCP. Now, like after any surgery, we teach the patient to report signs and symptoms of infection, specifically a UTI, that burning pain, and also report urinary retention. Lastly, we teach the patient to increase fluid intake to flush out sediment. So HESI mentions this: instructions for a patient who has just undergone a prostatectomy. Observe for signs and symptoms of UTI and ensure fluid intake of 2 to 3 liters per day. Now, a common NCLEX question: prostatectomy 5 days ago with small blood clots. The first action is to advise the client to follow up with the HCP immediately. Yes, it's outside that 36-hour window, so we should not be seeing small blood clots. And a few Kaplan questions. Expected assessment immediately post-TURP. Bloody urinary drainage is correct. Now, 24 hours after a TURP, the nurse notices bright red urine. What's the first action? Contact the healthcare provider immediately. Yes, the key term here is after 24 hours. Remember, durations are critical here, so know those numbers. And lastly, the 3rd day post-op TURP, the catheter is removed, and now the patient has uncontrolled dribbling after urination. So this is completely normal. Temporary incontinence is expected following urinary catheter removal. In terms of complications of bladder irrigation, clogging of the Foley catheter from blood clots or sediment can cause severe pain from the backup of fluid, resulting in bladder distension. This typically happens when the infusion is going too slow, so we simply manually irrigate the tube to loosen the clogging and maintain the flow. Now, when a question says that a client is reporting severe pain with continuous bladder irrigation after that TURP, the first nursing action, write this down, you have to assess. Guys, always assess. So, assessing the amount and urine output, and light pink color is best. Remember, assessment always comes first. Do not give pain medications first. The key word in most question banks is bladder irrigation. So assess the bladder first by assessing the urinary outflow. So remember, let the question help you here. Don't assess the abdomen. Don't even assess the bowels or other parts of the body. Always assess the bladder first. Many students got this wrong. Now, the second top test tip to write down is the output should be more than the input, not equal to and not less than, since the output would include irrigation fluids plus the normal urine put out from the kidney. So don't let the NCLEX trick you here. If you put in 2,000 mLs of fluid to irrigate, you should get out more than 2,000, more like 2,500. So simply think, anything less than or equal to the input indicates a serious obstruction. Now, if there is an obstruction, as stated before, we simply use manual irrigation with sterile normal saline until either the clots are cleared or urine color shows clear or light pink. Again, color is really vital here. Light pink is typically best.
All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides.
Now for renal lab values and urine analysis. Again, use the memory trick HOOK, H-U-C, since the kidneys sort of look like a pirate hook. Now H is for hydrogen ions, U is for urea, for blood urea nitrogen, and C is for creatinine. So starting with H are hydrogen ions. These are very acidic. So during renal failure, we have failed washer machines, right? So acid builds up in the blood and clients end up in metabolic acidosis. So a pH below 7.35, which damages the muscles, bones, and the kidneys. Now, a common test question asks about a list of clients most at risk for metabolic acidosis. So just think here. Metabolic means the kidneys and body, not the lungs here. So anyone with more acid in the body and not in the potty. So option number 1, renal failure. Well, think, are the kidneys broken here? Yes. Well, that means we retain more waste and retain hydrogen ions, that acid. Now, option number 2, pyelonephritis, is that kidney infection. So are the kidneys impaired? Yes. So we retain more hydrogen ions and end up in acidosis. Now, option number 3, a patient waiting for hemodialysis. So we have a patient waiting to get their blood washed with hemodialysis, right? That kidney machine that helps to filter the blood. So the key term here is they're waiting. So the blood is filled with acidic waste. So yes, they're at risk for metabolic acidosis. Now, option 4 is a little bit tricky here. Hyperventilation related to an anxiety attack. Well, this is a tricky one. It's not necessarily the kidneys. We have a risk for respiratory because of the rapid breathing, specifically respiratory alkalosis. That hyperventilation because we're blowing off that CO2. So just think acid. Carbon dioxide we call carbon diacid. So the memory trick we use, just think of a dog breathing like alkalosis, hyperventilation. Now lastly, option 5, a child with diarrhea for 2 days. Well, yes, they're at risk for metabolic acidosis, but we'll cover more of this in the acid-based lectures. But real quick, diarrhea does cause metabolic acidosis for a different reason. It's because they poo out all their alkaline, that base, inside the GI tract. So just think, base comes out the butt. So clients end up with an acidic body and end up in acidosis. Or just think if it comes out of your acidosis, like diarrhea, well then you'll be left with metabolic acidosis. Now U is for urea, that BUN, blood urea nitrogen. The key number to know for exams is 10 to 20 maximum. Now this is a byproduct of protein waste after the body consumes the nutrients it needs from protein, which I call it the protein bar wrapper, since it's basically the trash that the body needs to toss out. Now, before it becomes urea, it starts as ammonia, which it gets sucked into the liver to be broken down into urea. Then it gets pushed into the blood before it's excreted by the kidneys, from the body into the body. Hence the name blood urea nitrogen, that BUN. So BUN can be high for various reasons, but most commonly due to dehydration. So just think, if the buns are high, then the body is dry, typically. Or we say if you got burned buns, then you stayed out in the sun too long and you got dehydration. So if your buns are burned, then your BUN is typically high because the body is dry. Now C is for creatinine, our most critical kidney lab value to assess kidney function. This one is the one to know by far for nursing exams and the NCLEX. Once again, the key number to know here is over 1.3 means bad kidney. That is the key number to know. We'll be saying it multiple times throughout this renal course. So creatinine is a waste product produced by the muscles, coming from normal everyday wear and tear. So the higher the creat, the higher the kidney impairment, since it shows if the washer machines, the kidneys, are getting clogged up with muscle waste and impairing its function to wash the blood. So the memory trick is the 3 C's. For creatinine, just think critical kidney lab value that shows, third C, clogging of the kidneys with muscle waste, indicating kidney failure or kidney injury. Now for a quick study tip, always focus on the max ranges for pharmacology and lab values. Since the NCLEX and nursing exams mainly focus on how drugs or values will harm the patient. So safety is priority here. They want to test and see if you're going to be a safe nurse. So always focus on the max ranges here. So the key numbers for the NCLEX and nursing exams for renal function, just in case you missed it, BUN is 20 max, Creatinine over 1.3, just think bad kidney. And urine output 30 mLs or less, just think the kidneys are in distress. Now, a common NCLEX question. A client with infected toe due to diabetes is scheduled for a cardiac catheterization with contrast. Which lab value should the nurse report to the provider? So option 1, blood urea nitrogen level of 19, that is borderline. So no, technically it's less than 20, so we're okay. Option 2, a blood glucose of 155. This one's close, it's a little elevated, but it's typical for diabetic clients. Now option 3 is the one to know, creatinine level of 1.9. Yes, that's way over. Remember, creatinine is the critical kidney lab. So creatinine over 1.3 means bad kidney. And contrast kills the kidneys, which we cover in our cardiac lectures. Now option 4 is incorrect. A white blood cell count of 14,500. No, elevated WBCs are typical because the key term here is infection, since the client has an infected toe. So we expect those WBCs to be high. Okay, now in terms of blood tests, something that's really big on pathophysiology exams. Number 1 is we'll see metabolic acidosis from decreased GFR, that glomerular filtration rate, as the body cannot get out acid from the body and into the potty. Remember, hydrogen ions turn the blood acidic. So if the kidneys aren't working properly, we can't get those hydrogen ions out of the body and into that potty. Next is anemia from decreased erythropoietin secretion. Remember, erythropoietin is the hormone produced primarily by the kidneys. It tells the bone marrow to create red blood cells, those RBCs, which carry oxygen from the lungs to the rest of the body. Next test is the antibody level test with post-streptococcal glomerulonephritis. Woo! Big fancy words for immunity buildup after damaging strep throat infection has traveled down to the kidneys, causing massive irritation and inflammation. That resulted in glomerulonephritis, which we cover in a separate video. And lastly, elevated renin from the RAS system, the renin-angiotensin-aldosterone system. The kidneys cause hypertension in this case. So just think the memory trick. R for renin retains fluid in the body and not in the potty. And last but not least, we have our UA, the urine analysis. So for color, light typically means hydrated and dark urine typically means dehydrated. Now there are certain cases when this doesn't match up. So for example, like when we dump too much urine in DI, that diabetes insipidus. So we end up diuresing a lot of fluid and end up with light urine, but a dry body. Or on the other side of things, in SIADH, we stop urinating. So we end up with dark urine and a really fluid-filled body. But we cover that in full detail in the endocrine lectures. Now for specific gravity, students get this confused all the time, so pay attention here. The key numbers here are 1.003 and 1.030. So let the name help you here. Specific gravity, just think gravity here, the weight of the urine. So the memory trick we use is for light urine with a specific gravity that is low, just think a low and liquidy body. Very dilute urine, so we have a dilute body with low liquidy lab values. And on the other side, for heavier urine, the gravity is high, so just say the body is dry. Now be sure to memorize these numbers because the last thing you want to do is get those zeros and threes confused. Now if you see RBCs or blood inside the urine, this is known as hematuria, typically due to kidney stones, bladder cancer, or even trauma, like after prostate surgery or a procedure. And WBCs, those leukocytes, is general infection like a UTI or a kidney infection. So clients will complain of burning during urination. Now nitrites, that's a key term there. This is typical for kidney infection like a pyelonephritis. So just think of the N's here. For a kidney infection or pyelonephritis, we check for nitrites. Now if either are suspected, we can always do a culture and sensitivity test. So culture identifies the bacteria, and sensitivity, which antibiotic is the bacteria most sensitive to best kill it. So we take a sterile urine sample, and the key number here is over 10,000 organisms per ml indicates a UTI. Anything less for a culture is normal. And the last two here, protein and glucose. So if protein's high, that typically means nephrotic syndrome, which I call nerfrotic syndrome, like a bunch of Nerf balls inside the urine. And if glucose is high, that typically means diabetes, that really sweet, sugary urine there. Now, a common NCLEX question gives you an exhibit with all these screwed up UA values. So be sure to focus on the ones that are out of range. So a specific gravity that's high, and a little side note, don't get confused with the 0s and 3s. That's a high specific gravity there. Glucose that is high, and leukocytes that are medium. So right off the bat, you're thinking, if it's high, then the body's dry, right? And for glucose, you're thinking diabetes. And leukocytes, I'm already thinking infection. So the question asks a client with a history of diabetes, okay, which does the nurse suspect? The correct answer is dehydration, some question banks said low fluid intake, and possible UTI, that urinary tract infection. So perfect, the SG was high, so the body was dry, right? Dehydration. And we had leukocytes, so obviously an infection, UTI. Now for another patho side note here. Other key terms that appear on exams, you should write these down. Normal urine looks straw-colored with mild odor. This is normal. Now dark urine could be from hematuria, that blood in the urine, bilirubin from liver disease, or even concentrated urine with high specific gravity, typically from dehydration. As you know, hematuria means blood in the urine. So with a large amount, this is considered a hemorrhage. And for a small amount, it's typically seen with infection from all that scarring inside the bladder. Now, unpleasant odors is usually from infection. So just remember, UTIs could cause hematuria and definitely unpleasant odor, as well as cloudy urine from bacteria or pus, or even protein or blood inside the urine. Now, for a Kaplan question, it asked a procedure for collecting a sterile urine specimen from a Foley bag, and it was an order response question. So the correct sequence is, number 1, clamp the drainage tube below the port. Number 2, wait 15 to 30 minutes. Number 3, scrub the port using an antiseptic swab. And lastly, number 4, attach a sterile needleless device to aspirate a specimen via the port. But I wouldn't focus on this one too much. It was the only question out of about 10,000 questions we surveyed here. So I would focus on the critical values. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love. Share with Dialysis is the machine version of the kidney, used for our clients in renal failure, that kidney failure. So just like the kidney, dialysis helps to clean the blood like a washer machine by filtering out waste and flushing out excess fluid and electrolytes. So the memory trick we use, anytime you see the word dial for dialysis, just think dial like the soap. It helps to clean the blood. Now we have two types, hemodialysis and peritoneal dialysis. So for hemodialysis, a shunt is placed into the arm where blood is taken and washed in the dialysis machine, around 3 to 4 times per week. So if a session is missed, then we have a huge risk for excess electrolytes and waste in the blood. The one to know for exams and the NCLEX, write it down, is potassium. So just think potassium is priority since it pumps the heart muscles. So in high potassium, we have high pumps in the heart, leading to ECG dysrhythmias. Lots of exam questions come from here, so write this down. Priority is to give calcium gluconate to glue down those heart muscles, and then we also give IV regular insulin to push that potassium into the cell, out of the bloodstream, into the cell. Now, we go into way more detail about this in our renal failure lectures, but I wanted to give you the most tested content here to reinforce it. Okay, now as far as priority assessments before dialysis, it includes the double F's here, fluid and fistula assessment. So write this down. To assess fluid status, we always take weights, and we compare the current and previous. So we must check the medical record to compare the current weight with the last post-dialysis weight. And we always take vital signs and assess for edema, and also lung and heart sounds. Now, in terms of assessing the fistula, the shunt, huge NCLEX tip, write this down. You have to always feel a thrill or vibration on some question banks and hear a brute or a swoosh. So just remember, feel a thrill, hear a brute. If these are not present, we have to report to the HCP immediately. This could mean that there's a clot formation in the fistula, basically decreased blood flow, and the client can lose their arm. Now, in terms of which medications to hold, we always hold meds that cause low blood pressure, since fluid is removed during dialysis, which may cause hypotension, that low blood pressure. So to make this simple, for all the antihypertensives, simply remember A, B, C, and D. A is for ACEs and ARBs, ending in pril and sartan, like lisinopril and losartan. Just think prils are like a chill pril for the heart, low blood pressure. And sartans kind of sound like relax man with sartan, decreased blood pressure. Now, a little side note, both retain potassium in the body, causing hyperkalemia. So for P in prils, just think P for potassium. And the S in sartan, just think they spare potassium. Now, B is for beta blockers ending in LOL, like atenolol. So just think of the double L's for the double lows. 2 L's for 2 low cardiac vitals, low blood pressure and low heart rate. Now, C is for calcium channel blockers, ending in D-pine, amyl, and Zem. So D-pine, just think it declines the blood pressure. And amyl is calm and chill blood pressure. And then Zem in diltiazem is like Zen yoga for the heart, decreased blood pressure. Now the last 2 Ds, D is for diuretics, ending in ide, like furosemide and hydrochlorothiazide. So just think they end in ide, so the body is dried, and it lowers the blood pressure. And the last D is for dilators, like nitroglycerin. So just think nitro, vaso dilates the vessels to make that BP low. Now lastly, in terms of washed out, certain medications are dialyzed out of the body, making them ineffective. So antibiotics like Cillins and Cephs, penicillin and cephalosporins, as well as digoxin, that cardiac glycoside, which gives a deeper contraction in heart failure and AFib patients. So just think digoxin for digoxin. It digs for that deep contraction. And lastly, we hold water-soluble vitamins, vitamin B, C, and folic acid. Now, commonly chosen wrong answers was to hold calcium supplements. These ones are okay to give before dialysis to help bring down those phosphorus levels in the blood. And insulin is also okay to give because it's typically absorbed fast, so we can still give it with breakfast prior to dialysis. Now, a little side note here. During dialysis, IV heparin is added to the blood to prevent clotting. So it's not necessary to give subcutaneous heparin or another blood thinner before or during dialysis. So don't get tricked. Now, ATI had a question about a client who reports muscle cramps and tingling in the hands. You must prepare to give calcium carbonate. Just think calcium calms the cramps. And another question about priority assessment finding with hemodialysis clients. Key term here is restlessness. It could indicate deadly disequilibrium syndrome. Now, what the heck is that, right? Well, it's a deadly complication during or after hemodialysis. So write this down. Dialysis disequilibrium syndrome, that DDS. It's a condition where solutes are removed too quickly from the blood, which causes brain cells to swell with fluid. We're talking a big, massive brain here, resulting in deadly increased ICP, that intracranial pressure, which eventually leads to coma and then death. So the key signs to write down, restless and disoriented were the biggest ones there. You have to know those. During dialysis or even after is a priority, as well as vomiting and headache. Now the priority action is to stop or slow the infusion, and key term here, report to the provider. So don't let the NCLEX trick you here. We do not place the client in Trendelenburg, as it can increase pressure in the brain, making that ICP worse. Many students get this wrong. And we do not give medications to stop the vomiting or even the headache. Again, a general NCLEX tip, any infusion causing a problem, we stop or slow the infusion immediately and contact the provider. Now for patient education in terms of care for a fistula, You must understand how it's created before you can properly care for it. So creation involves a connection between an artery and a vein, typically near the wrist or the forearm. It permits high pressure arterial flow to go through a low pressure vein. Now, veins are typically not used to high pressures, since veins vacuum blood back to the heart. So it takes a few months to heal and settle in. Therefore, teaching the client is key. So, key terms here to write down: squeeze or grip a rubber ball or a sponge or something soft a few times a day to help both blood flow and strengthen the new site. And also, pitting edema is normal. Write that down. Big test tip here. Most students get this wrong. Edema, that fluid buildup in the arm, typically resolves on its own within a week or so as the body adjusts. Now, what's not normal, we must report this to the HCP. Huge NCLEX tip. Remember the 5 P's of perfusion. But really, the earliest signs to know are the top 2 here. So P for pale skin, that pallor, and P for paresthesias, that numbness or tingling. Now, these 2 are the top to know since they're the earliest signs and the most tested. Now, we also have the other 3 below, but without immediate action, a patient can lose their arm from lack of oxygen. So again, out of all these, the top 2, pale skin and paresthesias, very common on exams, since early intervention will always save life and limb. Now, another priority here is that clients must be careful with new shunts as they heal. So we have to avoid all pressure and monitor for key terms: infection, that warm red or drainage at the shunt site, bleeding, as well as, big one here, write this down, feel a thrill, feel that vibration. This means blood flow is adequate. So teach clients to check this every single day, a few times a day. That came up a lot on question banks. We're monitoring for the stenosis, basically that stiffening, or even thrombosis, that blood clotting at the site. So just think you have to check for those good vibrations. Okay, now for the no-nos. Just think here, we're trying to promote adequate blood flow and prevent that clotting. So we must avoid all pressure. So no restrictive clothing or jewelry, especially watches or even bracelets. No blood pressure on the affected arm. No sleeping on that arm. No creams or lotions in terms of infection, and no lifting over 5 pounds. So a key term here is no purse. These guys love to show up on exams as select all that apply questions. So be sure to think of the no-nos as no pressure. Now, switching gears to peritoneal dialysis. This is very different than hemodialysis in that there's no shunt in the arm. Instead, the peritoneal cavity is filled up with hypertonic solution to pull out solutes. We allow the fluid to sit in the body for about 30 minutes. This is called the dwell phase. And then we empty the drain to gravity. So the key points here is before, just like any dialysis, we take weight and we warm the solution. Typically, as a general rule, any fluid that's going inside the body, we want to make sure it's warm. Now, Kaplan mentions proper preparation for peritoneal dialysis. The first action is to warm the dialysate. Now, the big key point out of this entire lecture is the deadly complication of infection. So write this down. Infection risk. We must use sterile technique as priority when spiking and attaching the bag of dialysate. A small infection can lead to a very deadly infection in the peritoneal cavity. This is known as peritonitis. So the key signs to report, write this down, is fever, tachycardia, and cloudy drainage. We must report to the HCP immediately. So the memory trick we use is think no one likes cloudy days and no one likes cloudy drainage. Now, don't get tricked. Priority findings are not oliguria, that low urine output, or even pruritus, that itchiness of the skin. These are common and normal findings with almost all renal failure clients. So oliguria, just think no or very low urine output in oliguria. This, again, is normal and expected because the kidneys have failed. They're basically broken. Now, another deadly complication here is respiratory distress due to rapid infusion or overfilling the abdomen. So the key signs to know are crackles in the lung bases, rapid respirations, and also dyspnea. that difficulty breathing. So priority intervention is the first action we have to raise the head of the bed. Remember ABCs here. Breathing over circulation, like blood pressure. Many students get this wrong on various quiz banks. So always intervene on breathing before that blood pressure. Now, Kaplan gave a scenario about a patient on peritoneal dialysis that begins to suddenly breathe more rapidly. The first action here was to raise that head of the bed. And lastly, a few select all that apply questions came from insufficient outflow. So big NCLEX tip here. We always assess the patient first and then assess devices after. And always assessment comes first before interventions, which comes second. So when you get a question about insufficient outflow, we always, number one, assess the patient, assessing the abdomen for distension and constipation. Number two, you assess the device for catheter kinks and obstructions. And then very lastly, the biggest intervention here, write this down, we reposition to side-lying position. We don't flush the tubing initially. This can worsen an outflow problem. And there's no need to contact the provider, since repositioning will usually fix the problem. Now, after dialysis, we typically increase protein in the diet, since the blood has been washed from waste, and now we typically have low protein in the body.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guide.